So here you are watching drug-induced sleep endoscopy with BIS monitoring in a 54-year-old male with history of snoring, choking, mouth breathing. His body mass index is 27, just a little high. His apnea-hypopnea index is 18. As you can see, he's got a little deviated septum on the left side here, the cartilaginous part, the nasal valve area. Apart from that, there is not much of deviated septum. The turbinate hypertrophy on the right side. Now, as we try to go inside, there are no adenoids. The salpingopharyngeal folds are not grossly enlarged, but I'm just putting some more drops so that the patient goes back to sleep. So, with the introduction of the scope, the patient has woken from the sleep, just waiting for him to again go back to sleep and start snoring. That's the salpingopharyngeal fold. I can possibly rate it as grade 1 between 25 to 75%. And as we go down, you can see the velopharyngeal tube, the lower part of which is obstructing. The upper part of the velopharyngeal tube is wide, lower part is narrow. Lower part is made up from the distal part of the soft palate. You can see the concentric collapse. This is now in the sub 80 range. So that's the correct range of this. Now it's perfect. This is in the perfect range of late 60s, and you can see a complete collapse of the soft palate. So there is no tongue base or epiglottic collapse. It's a purely palatal collapse, which is both antero-posterior as well as lateral. So now I'll try closing this patient's mouth and see what happens. So when I close his mouth, still the soft palate is still collapsing. So because of the deviated septum on the left side, the patient has a tendency to keep his mouth open. And when I'm keeping his mouth closed, he's trying to resist because he still wants to breathe from the. Now I'm keeping him on right lateral side, and we'll see what happens. At the base of 74, the snoring is persisting. The collapse is obviously little less than as compared to the supine position. This is the right lateral. And we can see that its lateral collapse is equally important. So not only anterior posterior collapse. Now we'll turn the patient on the left lateral. As we turn the patient to the left lateral, you can see again the lateral side of the pharynx is collapsing more than the AP. So we understand that this patient has predominantly a palatal collapse, so he would require uvulopalatopharyngoplasty, suspension bridge, along with septoplasty for this high deviated septum, as you can see on the left, more on the cartilaginous part, and turbinate hypertrophy. So turbinates have to be shrunk. Thank you for